Good afternoon, everyone. I hope you had a good lunch, and I would like to thank NIDEC for this kind opportunity for introducing us to these wonderful equipments and allowing us to interact on how we use and learn from them. What I'm going to talk to you about is our experience of using the multi-spot, multi-wavelength lasers, as well as some experience with the microperimeter, which you heard about, and the OCT. So we've been using the multi-spot laser for a while now, and originally the Pascal came in, and that's what changed the way we were looking at a single-spot laser. And we were used to lasering in a certain way, and then suddenly all that changed with how we started handling the multi-spot laser. And now we have different options to do that. So this on the left, what you see is the original big design of the Pascal laser, and now you have the Vixi, which is doing multi-spot as well as multi-wavelengths, which means that there are 3 different wavelengths which you can toggle just by changing a switch. So you get a multi-spot, as well as you change the wavelength depending on what area you are shooting, and you want to spare certain other areas. Moreover, you get, with the multi-spots, you get these patterns which you can customize depending on the area that you are going to treat. You could customize it. You could have a circular pattern, a semicircular, squares, and a lot kind of patterns which you can customize to a particular area, especially when you do macular lasers, you need to customize it. Or if you're treating a hole or a tear in the periphery, you need to have a different kind of pattern as compared to the regular square ones that you are used to. So standardly one would use for PRPs these square-shaped patterns, usually 25 spots, 5 by 5, or you could reduce or increase it depending on what areas you are treating. So here you're kind of treating areas in between previously treated areas, so the spots could be titrated accordingly. And when you do macular lasers, as I said, you could customize it based on the area of thickness that you see. So this is for the grid laser that you see, the spots, you can do a semicircle and then treat them, titrate the spots, and then treat only in a localized manner that you see. So at that point of time, we'd done a whole comparison of looking at how the collateral damage works with the single spot high fluence energy burn compared to these multi-spot burns which have low fluence and cause lesser collateral damage. So as you can see from these images, on the left you see something which is very well uniform spots. On the right you see manually done single spots and how they overlap the burns. And on the red free you see that much better, as in how the uniform spacing would actually affect the fields of the patient possibly when you treat them eventually. And look at the single spot ones where there's a lot of overlapping no matter how well we do these spots. So we'd done the comparisons, and we'd found the regression achieved with both the single as well as the multi-spots were pretty much similar. The pain scales and the patient comforts were much better with the Pascal or the multi-spot Vixi, because as we said, the time goes down to treat them. The comfort zone of finishing your laser is much faster before the patient realizes you're already done with so many number of spots. Moreover, we also looked at the spot enlargement. We looked at the infrared spots, and normally all laser spots tend to increase in size over a period of time, and these low fluence burns tended to not increase the same way as the regular single spots do. So we found a statistical difference to some extent on those as well as the fields which were done in these patients, although not statistically significant, tended to show better sensitivity at the end of this. And we published this data in 2010 at that point of time. And then recently we were comparing all the 3 wavelengths, and while comparing, what we did was in the macular edema we did 3 line scans of one using a yellow, one using a red, and one using a green with a similar power setting, and then we did OCTs to these patients. And you can see that the top one is the green one, and you can see the extent of damage which a spot causes in the layers of the retina. The yellow one is in the center and the red one is at the bottom. Red goes in much more deeper. The yellow tends to be a little more superficial and less damaging to both sides, while the green tends to go in a much bigger spot. And this is the follow-up of these spots that you see over a period of 1 day immediately post laser to 7 days, and you can see how the laser marks regress. This is for the green. This is for the yellow. As you see, it becomes extremely localized, and that's what helps in the macular area, that you might be reducing the amount of collateral damage if you use this. And this is red. Of course, it goes in deeper to some extent, but you can see these comparative regressions which happens with each of these wavelengths, which is interesting to note. And we published this recently, and also presented at the San Diego meeting, this whole comparison which I talked about. And these are some of the patients where we use the yellow laser in a multi-spot manner to treat. These are bilateral exudation with thickness change, and how well they respond to this sort of a laser-based treatment. And of course, a lot of them you do combinations with anti-VEGFs because you need to bring down the thickness. And then once the thickness is down, you do very minimal damage. And clinically, you don't see these burns as well, but you do red-free images and you see them better. This is, again, examples of a priorly treated patient with a lot of laser that you see, and then he comes again with some kind of an edema, and that's when you want to reduce the thickness and then treat them with a very minimal grid laser in these cases. Also for vein occlusions, what we usually do is if you see peripheral ischemia, you do a sectoral laser. You see the uniformly spaced burns in the periphery, and in the center, on the macular area, you would do a very light grid if required. This is central vein occlusion. Of course, here we don't do macular laser, but you would treat them either with an anti-VEGF or an Ozurdex. This is a patient treated with Ozurdex. Very effective to reduce edema, but then we all know that there is a recurrence of these patients as soon as the effect of the drug goes away. So very typically you get a regression, and then at the third month you start getting back. So we believe that these patients should undergo some sort of a peripheral mild laser, even if they don't show gross ischemia at the end if they are recurring. So on a recurrence, what we usually do is we would do a PRP with multi-spots in these cases, a lighter PRP as compared to the ones which we would do for diabetics to some extent. And if you see frank CNP areas, of course, you would treat them the same way. So this is a patient where there's already a Ozurdex injected inside. With the recurrence, this is a second injection that you've made, and then you're also lasering them at some point. The same goes for BRVOs, where you see recurrences, and those we would put them to a mild sectoral laser at some point, grid laser, so that the recurrence rates or the re-injection rate becomes less. Most of these patients we either treat with 3 injections of anti-VEGF and then follow them up depending on if they require more, or given Ozurdex. So you titrate the burns in the periphery and then bring them to the center in the macular area, and then customize your grid which you like for that particular area of the thickness, and then treat it. So it becomes very easy. It's very fast. The multi-spot allows you uniformity, control, and extremely fast that you can laser. So this is about the laser, and a few images. You already heard a lot about the OCT, the fantastic stuff. I'm just showing you some of our experience because what we noticed is that with this particular Nidex OCT, the vitreous interface is seen much better than what we see with many other OCTs. We use the spectralis also, and it gives wonderful images, and I think they're very comparable images, but the vitreous interface here is interesting. So this is like you see toxoplasmosis in an active form, and if you look at the way the vitreous just adjacent to that whole inflamed lesion is, gives you this very strong kind of density of active cells which is there, which is picked up very well with this scan. And this is on follow-up. You treat the patients and you can actually see how well that whole area, apart from what happens clinically, you also see on the OCT. So it's a great way to document how this whole inflammation is going down in an objective manner. Hopefully, we might have a way to grade it. I still have not seen much on that. I would love to have a way of that we could grade the amount of cells based on the inflammation. Maybe Dr. Sada might have some answers to that at the end of it. He works a lot on that. So these are some examples of that. This is cysticercosis. We find it once in a while back home in India, and you see these worms coming up, and look at the way the vitreous interface is seen on top of the cysticercosis with that infiltration which is seen, which tells you that there is a localized inflammation coming on top of these areas. And these are choroiditis, where you also see the deeper choroidal areas which tend to be much more thickened. The larger vessels of choroid tend to show much more thickness. This is a CNVM, and you see the nice hyaloid which comes in and also attaches on the fovea. This is disc edema, optic neuritis, and you see the follow-up, and then you can do very nice graded scans on the sequential follow-up to see how your patients are doing. And the other good part is that these are long scans, 12 millimeters. So you can actually go and take the full scan from the nerve head to the end of the macula instead of having different areas. So for patients like optic nerve pit and all, you can actually see where the pit is in continuity to the whole extent of the lesion, which is very impressive. This is an IPCV where you can also see polypoidal changes. If you compare the areas we do on ICG, sometimes you look at exactly the polyp and pass the scan there, and you can see that these are, of course, vein occlusions, vitreous hemorrhage showing the vitreous infiltration and the scaffold of the hyaloid, the way it comes in. So these, the clarity of these interfaces is getting better, and it helps us treat the patients and then follow them up objectively. I think that's what is getting better. This again, choroiditis showing the choroidal and involvement much better when you do these deeper scans on these patients. This is on the healing scarred areas that you see changes of some sort. And then now we go on to some experience that we have of microperimetry. I'll not go into the details of its functioning. You already heard that. I'll just show you a few cases as to where we can objectively see. In CSR patients, we see a clinical improvement, but the patients always complain of some sort of a residual problem, and even when the macula becomes flat. And I think the microperimetry tells you exactly what's happening in these cases. So this is an example of a CSR which is not resolving over a period of a month, and then you do a microperimetry and you see what exactly are the areas. The red ones are the one which are seeing less, the whole area of that, the elevation which is there. And then the leakage site, we do a very mild yellow laser to that, not non-seeing burns usually, and then on the follow-up the patient has flattened. You still see the hue of the circle on the red-free image, but the macula is flat, and this is the microperimetry there. You see them all becoming green, but there are a few yellows around, which tells you that there has to be some subtle defect, which is why the patient is not, always will tell you that this eye is not the same as the other eye, even though the macula looks flat. So this is the pre and the post of that treated eye, and then you see the comparative, the microperimetry readings, what you are seeing here. And this is the site of the leak, where if you look at the leakage site and the laser done, it's hardly kind of showed up. It's a minimal laser which is done. It does not show up too much on the microperimetry. This is another case similarly. It's not an optic nerve pit, just a CSR, even though it tends to go closer to the disc, and you see the leakage site as well. And this one had a microperimetry scan like this. Again, we lasered and as flattened, and you see the reds becoming more green and orange or yellow to a large extent. This is the pre and the post treatment of these patients. So you can see the comparative spots at every single area. So I think microperimetry helps you objectively document this aspect of the condition, where the patient is talking about his contrast, or he's talking about the color desaturation that he feels in spite of your having achieved the macula flattened. This is a patient with a CNVM. You see a scar, and just below the scar you see a reddish hue. So there is a formation of a CNVM starting from the edge of a scar. The OCT tells you exactly where that's happening in relation to the scar, and we do the microperimetry, and you can actually see that the scarred area, of course, is red, but even the area just below where the recurrence is documented quite well, and the reddish hue which is showing up there, and that's where the fluid is accumulating. And then this is on after the injections you give, and you flatten that area, and then when you pass the scan, that lower reddish area tends to become green comparatively. So these are the pre and the post treatment, and now you can compare exactly how these spots are changing in relation to the microperimetry which is done. Macular hole is another area where you could document what's happening pre and post-op. This is a classic case. Your patient undergoes surgery. This is the pre-microperimetry pattern, what you see. On the follow-up, you have a closure, and then when you do the scans, it takes a while. We've seen it can take up to 3 or 4 months to sometimes have better recoveries. Initially, when you do, you might still see a lot of red in that area which is there. This is the pre and the post, and here you still see some of the red which is there. And it also depends on, again, the history of the hole, how long it's been there, and that's why even the visual acuities are correlated based on how long the hole has been, what grading the hole has, and sometimes the patients don't recover much vision. So microperimetry is a good way to document exactly what's happening on every given point of the closed area of the hole that you see. This is another case of a macular hole which you see on a pre-surgical one, and this is post-surgery follow-up that we see on a closed hole, and now when you do it, this is an early hole, smaller hole, does much better. You see the reds turning into greens much more effectively in such a situation. So there's a lot you can do with it. There are a lot of conditions. I'll not go into the details of a lot of different things, but a lot of macular conditions Dr. Sadda has also talked about. I think it has a lot of potential where these things are concerned in a way of objectively documenting. So I think if you combine the use of all these things, the OCTs, the microperimetries, and you have lasers to treat conditions, in a combined way, you can use the technology much better to do the least collateral damage and still achieve a satisfactory vision for the patient. Thank you very much.